Welcome to the Fix Your Sciatica podcast, where we meet with experts and clients and discuss how to manage your sciatica and low back pain without the use of medications or surgery. I'm your host, Dr. Ashley Mack, and I'm a physical therapist as well as the founder of ifixyoursciatica.com, a go-to resource for pain management. So here at ifixyoursciatica.com, one of our biggest focuses is to help you relieve yourself of your sciatica pain without having to use medications or even minimize the chances of surgery. But there are some cases in which surgery is in fact indicated or could be extremely helpful. And there's a lot of misconceptions in regards to what surgical approaches are there, are they effective, and even how to actually recover from all this. And so today's guest is a very special guest, physical therapist turned neurosurgeon. And I found his profile via LinkedIn, and just looking at all his work, I'm a huge fan. And he is the founder of his own neurosurgery clinic, and he is just a brilliant human being. So in today's episode, I have Dr. Michael Verdon, neurosurgeon. Dr. Verdon, thank you so much for being on today's episode.
No, I appreciate you having me. Very humbled to be asked to tell my story.
It's really cool. So let's talk about your story. Let's talk about your journey to where you're at today, because I know that you've done some really remarkable things. But for the folks who may not have, come across your name or aren't from, I believe it's the North Carolina area, can you tell us a little bit more about yourself?
Hi. So I'm Mike Verdon. I'm a neurosurgeon. I actually practice in Dayton, Ohio. We have the software companies in Asheville, North Carolina, where my partners are there. I was a pretty normal kid, raised in Jersey, nothing. I went to college in Los Angeles, got a business degree about 1,000 years ago. We're using slide rules and parabolas before computers, really, and before the internet existed, and moved back to Jersey. I had gotten injured in high school and went to physical therapy, got better. So someone suggested I look into that. And I had no background in science and went to a clinic, and I liked the patient interaction and wind up a couple years later studying. The biggest thing, I guess my whole thing is about learn more. And so studying science and liking it and anatomy and applying to PT school and eventually getting into a PT school. In Wheeling, West Virginia, where we had a problem-based learning curriculum, and it was all about the patient. Everything was centered around the patient, and then you go learn it on your own. There was no teachers. You apply yourself to a book, you create your own learning objectives, and I actually thrived in that environment. I was not a terrific student as a kid when something was being shoved at me, but when I could pick what I wanted to learn and go learn it, it was really easy. I mean, you follow your passion, right? So finished PT school, wound up in a big university setting, and saw these medical students and thought, these people are sleeping in class. How come I can't go do that? And someone encouraged me to go to medical school. And so applied to medical school, and I got in. Again, it only takes one. So one interview, got into one school, and same thing. In a span of 2 weeks, I quit my job, moved, got married, started medical school. And same thing, I just applied myself I was paying for it, and I studied in medical school to maybe someday I could have something, learn something that would help somebody. And then we had a very visual, the way they educated us, and I decided I wanted to try to go into neurosurgery. I didn't really know why, other than I liked the nervous system. And I started hanging out with a surgeon who was doing spine surgery. And I was very suspicious of spine surgery prior to this. As a PT, I saw a lot of patients get hurt, and I didn't understand why. And I thought it was kind of like, didn't work. And then I went and hung out with the surgeon, and I watched a surgeon operate, and it was like watching someone paint. It was really kind of meditative and fascinating. The more present I was, the more amazing it became. And the patients actually did okay. They did well. And so I thought maybe there's something to this, and eventually I got into a neurosurgical residency program where I learned basic principles of spinal surgery from neurosurgeons and orthopedists both. So I learned how to do a fusion, which is typically thought of as an orthopedic procedure, and then a decompression. And so what the bottom line is, I left residency knowing a couple of things that spine surgery accomplishes. It can decompress a structure. So if something's being pressed on, we can actually go in there and take that away. It's usually bone or disc. If something is moving too much, we can stop the movement. So if there's instability, we can fix it. And if there's a deformity, you can realign it. And so really from a surgical perspective, that's what I look at now. What are the three things I can do? It doesn't say you go fix degenerative disc disease. It doesn't say you go fix a quote unquote, even sciatica. That's really a symptom complex. That's not the cause. So I left training realizing you have to clearly define a cause of the patient's symptoms that correlates to what they're feeling. So a lot of times you just, we were taught, look at the MRI. Well, the MRI has to correlate with the patient's symptoms. As a therapist, I learned how to take symptom-driven history very well and come up with what are the causes that could be doing that structurally, right? Muscle, ligament, bone, nerve, right? Neurosurgery training, it was more of, what nerve is being affected and what you do about it. So I was able to combine those two in integrated fashion and then practice doing that. And so my exam consists of a physical exam, which is more like what a therapist might do. To some degree, it's modified, and then a neuro exam, like a neurosurgeon should do, and then structurally finding out where their abnormalities are that relate to their symptoms. So it's your story. I always have to get back to the patient's story, and then devise a treatment plan. And in my community, I was the only guy seeing patients. I was like the primary care physician for spine patients, and not everybody needed surgery, right? The average clinic sees 20 patients for one surgical procedure done. So you see quite a few patients. The problem is if you're seeing that much volume, you cut corners, skip stuff, don't listen because we're all human, right? So you can miss what the diagnosis really is. The patients will tell me if I listen. So long and short of it, I started referring patients out for non-surgical problems to therapy, and I learned great things that therapy had come up with since I left, and dry needling and soft tissue techniques and all these wonderful things that I can't do. And in the meantime, I decided to come up with an algorithmic way to define pain generators off of using a combined history taking from both therapy and physician and surgery. And then you can kind of come up to a point of what's the most likely common cause and then treat it. And the treatment usually begins with conservative care. Not everybody should run to the knife unless you're neurologic trouble, meaning going to go paralyzed right now. And there's very few things that require surgery now. Very few. Like 2, maybe in the spine, 3 at the most. So that's kind of what we have come up with. And I've been practicing that for 13 years now. And we've developed machine learning software and triage software off that too to help other people get through this system and find the right doc for the right treatment at the right time, or right provider, right treatment, right time. And we feel like it's reproducible and successful and consistent. So in a nutshell, that's kind of professionally where I'm at. I mean, I'm personally, I have a wife, 2 kids, lacrosse dad, running around like crazy, but like everybody else. I have a full life, but this is just how the clinic decision making, and you have to kind of make it routine so it's predictable.
I really liked how it was this evolution from, say, like one concentration to another, but then based on your previous experiences, you were able to combine and say, okay, these are the best solutions. And I think one of the another really interesting thing was you talked about this concept of machine learning, and machine learning, artificial intelligence is all the rage right now. And
Right.
there's a lot of challenges there's a lot of challenges, also a lot of naysayers. But ultimately, I think what I'm most excited about when it comes to what you're building and what your team is getting out there is that there's it's a standardization, a reproducible opportunity. Because let's take, for example, just looking at MRIs, right? You take one MRI and you put it in front of 10 different physicians,
Yeah.
you're going to get 10 different answers, right? And so
Correct.
it ends up being very, very, there's a lot of varieties there, and it makes it very extremely challenging because of the fact that we're not getting a standard of care. And that's one of the big things. And I love the fact that you talked about this concept of problem solving and also focusing specifically on the patient. I wrote in my notes, it was like, it is your story. And from your story, we're devising a treatment plan. So it's really amazing from there. So you talked about it briefly, but let's talk about the three major reasons as to why someone would consider surgery. You were talking about decompression of a structure, bone or disc, stopping movement, aka instability, and then deformity, so realigning it. And so from what you've seen, let's talk about decompression specifically, whether it be a disc or some sort of bone. What are some of the common causes as to why someone actually would need a form of decompression? Do people just all of a sudden, they're walking one day and all of a sudden, boom, their nerves become compressed, or is it something different?
That's an awesome question. So I would call myself a community neurosurgeon, but really I take care of degenerative problems. So arthritic-based issues. If a disc is quote unquote herniates, it can happen quickly. Usually the symptoms get bad 24 hours after a disc herniation. Why? Because the disc herniates out for the most part, 90% of the time, presses on a nerve, and then the body sends inflammatory mediators to get rid of that disc herniation because it's not supposed to be there. It's actually identified by the body as foreign or not. So it sends white cells and all these different, it's leukocyte mediated white, I call them Pac-Men, right? So the Pac-Men are going out there to try to take out the disc. Well, the disc is right next to the nerve. Those inflammatory cells irritate the nerve. So that's why you get this hot leg pain after acute disc herniation, 24 to 48 hours afterwards. Sometimes it's a massive extrusion. That's an emergency. That's a different story. But one unilateral leg pain. So that would be a disc reason. So if you can't, I took a McKenzie A course as a physical therapist, right? If you can't reduce it or it doesn't get better from traction or position, and you could do a small laminotomy and go in and remove the fragment or the part that's compressing on the nerve. And that's a pretty common procedure. We call that a discectomy. When it's done under a microscope, it's called a microdiscectomy. People are now sticking endoscopes in spine. It's called an endoscopy. I mean, but it's the same thing. Take out the fragment that's pressing on the root is really what the goal is. Works very well, super reproducible. Does that mean it's treated the whole disc? No, it's the fragment that's hit the disc. Do I change degenerative disc disease with that surgery? No, I do not. Those are really nerve root surgeries in my mind. Pretty predictable. Patients usually do well. I mean, you can always have something happen. For the most part, everything goes fine and patients go home that day, next day. For bone and ligament, the joints grow bigger, right? So I like arthritis is like this. If you cut a branch off a tree and the bark starts to cap over where you cut the branch off, that's arthritis. So it's growing because it needs to stabilize around the spine. The nerve roots can be compressed with that. So that's where bone needs to be removed. You usually do it with a high-speed drill that looks like a Dremel or it's got a little diamond bit on there, and you can free up the root. And patients typically do well too. With that, that does not require a fusion.
Yeah.
That's kind of the two major things.
Yeah, so we got discectomies, and then we have what would if you don't mind me asking, what would the term be if they're doing, say, opening up a foramen and removing some of that bony arthritis? What would that technique be called?
So foramen, otomy means to open or to cut. It's called the foraminotomy, right? So lamina, you take the lamina off, laminectomy, or laminotomy, you make a hole, right? So foraminotomy is just opening the roots that exit out the spinal canal.
Yeah, that's a fantastic way to explain it. I think when patients go in to see a doctor, as you said, if you're seeing a ton of patients, you might not necessarily have the time. And then to be told when you're experiencing so much pain that you would actually be a good candidate for surgery, given all these options, or even just saying like, these are the techniques. I think also at that point, it's not necessarily being offered an option. It's really more so saying, based on your clinical presentation, the ineffectiveness or failure to resolve from conservative care, a discectomy or in that a different scenario, a foraminotomy could be particularly useful, and it can be very overwhelming. And so I think you explain it in a very simple, digestible way, which I really appreciate because so many people are so overwhelmed by the time they're even in the clinic itself.
One thing I've learned, someone told me, and I think it's true, no one, no one is coming to my office for surgery. No one. They want to understand what their problem is, and they want to understand how we can treat it. I think they need to be given the opportunity to say, I don't think that will work. But most people want a better understanding of what the nature of the problem is and the nature of the solution, right? So if the solution is, look, that probably won't get better with therapy, that probably won't get better with chiropractic care, it won't get better with injections, it really needs to come out. That will get, sometimes people, I'm not super pushy with patients about you have to have surgery or don't waste my time. Or, I've had people say that the doctor told me don't waste my time. I mean, I don't do that, but sometimes I'm like, this is what I'm recommending. If you don't want that, this is what it could lead to. It's your choice, because look, all sorts of weird things can happen in the operating room, even if you're super careful. I mean, we're all human, right? So it's got to be worth the risk. And I believe the patient has to believe in the treatment, has to. This is it. And a lot of people don't get to that point unless they've done everything possible, right? So as long as someone's not going to get paralyzed, and I'll tell them, hey, call me, I'll be ready for you, or whatever, or you don't need me. A lot of patients who come in really bad pain, I have disc herniation, it's been 2 days. You don't need me. Come back in 6 weeks, and they can't, what do you mean? I'm like, you really got to give yourself a chance to get better. But if I recognize that they're not looking for a surgeon, they're looking for solutions. So, and then if I explain them the solutions, it's a lot easier for them to understand and make a good choice. We've changed the way that the world has gone around medical decision making. It used to be, oh, okay, doctor, whatever you tell me, I'll do. That was probably a generation ago. And now it's like it's shared decision making. My goal is to educate you on a level that you understand, and I can guide you to what I think the best decision would be given your situation. But people have to understand what's going on. I think that when things don't go the way that you could expect them to be, maybe you didn't understand what the expectation should be, or what the outcome should be.
We are going to take a quick break to tell you about our awesome new program called the Sciatica Protocol. If you don't have the time to see a professional, but are tired of trying to figure out this recovery on your own, then the Sciatica Protocol is for you. Harness the power of a knowledgeable physical therapist through your phone. It takes no more than 7 minutes per day, and it is designed to help you recover as quickly as possible. It is simple to start, and all you need to do is log into ifixyoursciatica.com/the-sciatica-protocol and fill out the 9-question quiz to begin. The link for the program is in today's show notes. 100%. It's this concept of, we call it the alliance, right? The alliance that you create between your patient, your provider. You have to be able to believe, and in order for you to believe, and in order for you to have that trust, you have to be properly informed. And during a time where life is so overwhelming, you're experiencing this pain, and all you want to do is just get out of that pain. Yeah. We need to focus on addressing that problem, but it's together. And so let's talk about like this concept of conservative care, right? So usually surgery is the last resort in regards to, okay, you've gone through conservative care, it's not recovering. We briefly talked about at the beginning, there really isn't that much of a standard of care in regards to treating, say, even like from a physical therapy standpoint, how to address sciatica pain. Like you go like in a town of 15 therapists, you're going to most likely see 15 various different ways to treat this. And so for those folks who said, I've been through everything, this has been a long journey. For you, from your standpoint, how long is enough time for conservative care to be considered ineffective?
Well, I have a little bit of a different twist on this. I know it's hard to believe, but the clock starts the minute someone gave you a diagnosis. That means a structural anatomic level or specific pain generator. Because you're just getting treated randomly for a very specific problem. So that would be like putting water on smoke. It's never putting the fire out. So a lot of times patients will come to my office and I'll say, hey, okay, has any surgeon ever examined you like this? So I test their hip and their SI joint and flexion extent, blah, 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 all this stuff, right? No, doc. Has anybody correlated your symptoms with an anatomic level, meaning level of a disc or SI joint or hip, right? No, doc. Okay, well, we're going to have to try physical. We've already done physical therapy. So this is what I see a lot. Patients get put on traction. They have SI problems. Guess what happens? Their SI problems get way worse because you're pulling on their hips. You're pulling on their ilium, their ischium. It's worse. And it's not going to work. Well, how about we do gentle mobs or some sort of ligament drying? So I try to direct my patients to therapy with what I think a likely diagnosis is that will guide the PT. The PTs can make those decisions on their own, but this is another set of hands to say, hey, you guys might want to try to treat that. If they go there for 4 weeks-ish and no better, then injections at the same time. 80% of all comers, and we know this from our own surgical literature, the SPORT trial, which is a disc trial, right? 80% of all comers get better spontaneously in the first 6 weeks. And that means no therapy, no care, no therapy, chiropractic care, injections, surgery, right? Everybody's the same. At 2 years, that trial says that patients who have radiculopathy from nerve root compression, persistent nerve compression, the surgery patients tend to have symptom relief sooner, right? But so you have to at least try conservative measures first. Contain disc herniations, patients who can find positions of comfort, meaning less pain in their extremity on a certain position, those patients tend to get better without surgery. Not 100%, but more likely than not.
Yeah, I really appreciate you sharing that because, during those first 6 weeks, there's for sure an inflammatory component. And I love the fact that you said even if it's a positional improvement, because oftentimes when I'm working with my clients, I say, what are the positions that actually make you feel better? And then from there, how can we replicate that a little bit more, right? To be able to
totally do that now. That's in my, it's been a long time since I've had people do press ups or something like that in my office, but I've done it.
Yeah.
And so that's care model, really, right? If you're talking, that's kind of how I do stuff. I don't know as much as you around therapy, not even close. It's been so long, I haven't done it. So I don't claim to be an expert. I know enough about that to be dangerous to the patients. But at the same time, you have to give it a chance, give it a whirl, There was something else. The patients who fail conservative care and I have an anatomic diagnosis, they usually respond to decompression, stabilization, or deformity correction. So I'm already selecting patients that you're probably going to do better with surgery because you failed all those other things. So if properly worked up, the patients who wind up having to go to the OR, if it's like segmental, meaning 1 or 2 levels, it's pretty predictable. So therapy can be used to predict who would improve from surgery if you have a structural diagnosis. That's the way I look at it.
And that structural diagnosis will for sure actually lead to whatever treatment it should be, whether it be through conservative care. I think that's one of the big challenges that I have with a lot of, well, not a lot, but in some cases, people will come and say, hey, Ashley, I've been doing PT here and there, and these are all exercises I've been doing. And I think what ends up happening is that in some cases there's some physical therapy or just whatever profession, like even just like someone who's intervening is like, let me just give you this whole shotgun approach, all these different exercises, which it used to be that kind of standard of care, we'll say 10 to 20 years ago. But what we found is, and as you've noticed, is like building that trust, that patient-centered care, and to be able to, in essence, problem solve. And which then actually brings up, and you actually answered this earlier before, but I think it would be great to be able to reiterate it. But say, for example, say if the listeners are here and they're communicating with the doctor and they're like, okay, I think I may be a candidate for surgery, but after hearing this, I don't have I don't quite have a structural diagnosis. How do I bring this up to my surgeon, my doctor, to be able to make it possible to be truly informed and build that trust?
The best way the patient can talk to the doc is say, or the therapist or the chiropractor, say, I don't understand what my diagnosis is. Just start with that. If they can't explain it to you, they don't understand what your diagnosis is either. That sounds terrible, but like, so I'm going to put this out there and you can do whatever you want with it. Sciatica, that's a symptom driven term. Leg pain, back pain, buttock pain. So which we do, that's the effect. We're trying to make differences in the causes. What's the cause of the sciatica? In one of my lectures, I have like this slide where it's all the different causes of sciatica. It's piriformis syndrome, it's SI, it's hip, right? It's foraminal, it's extraforaminal, it's spondy. It's five. I mean, those are 5 different causes, 5 different treatments. So try to get to that. If they don't know that, then you need to find someone that can help explain to you what is spondylosis. If they won't take 5 minutes to tell you it's arthritis of the spine and explain what that means, then maybe they're not the best doctor for you or treatment person for you. We're here to educate, right? That's the whole basis of physical therapy is education. The patients need to understand what's going on with their body and modify that, right? So physician surgery is the same thing. That would be what I would start with first. I think the reason that happens, the shotgun approach, there's no standard way to evaluate and communicate about patients. That's how we came up with transcendent care and machine learning stuff that we're doing, because we feel like there's only one way to do a knee replacement. There's how many different ways to evaluate a spine patient. And that variability kills quality and predictability and outcome generation. It's time for that to stop. I mean, we're as a healthcare, as a discipline, corporate wise, if you want to say, is very immature. It's time to use technology to help ripen it, produce some reasonable, predictable outcomes,
100%. Yeah. And I think that's huge to be able to have a center. Again, there's really not that much. I mean, even if you see on the research sites, they're like general exercise program or like general something, and then you go in the study, they don't tell you. And so from there, you have various different certifications, bodies, groups that will actually say like, this is the best way. And you're absolutely right. Sciatica itself is a symptom. It can be caused by many different things. And it is important for whoever you're working with to be able to help identify that. So for the folks who are saying, okay, I think surgery is for me, and they're trying to look at once the surgery is done, right? There's a lot of things that you need to get done, but once the surgery is done, what's to expect after these surgeries? The recovery. I mean, there's a lot of different things, but from your end, what do you often tell your patients when it comes to, okay, you're gonna get this, but this is what to expect post surgery?
So the day before the surgery, I come to my office, we literally open up the films, talk about their symptoms, and I tell them what I'm going to do stepwise, right? We're going to put you on the table. I'm going to do this, 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 and this. And then I'll tell them, after surgery, you'll probably have incisional back pain, right? But hopefully your leg symptoms or arm symptoms would be gone. And I'll say it like that. And I was always told, don't do that. And some of it is patient expectation. If they expect to feel better, guess what they're going to do? They're going to feel better. Fortunately, with the lumbar surgeries, there's techniques to help lower or lessen the incisional back pain with So we're now doing field blocks. You used to do a femoral nerve block for total knee replacement. You can do field blocks in the low back, which help quite a bit. But until the month, so I tell them 2 weeks the skin to heal, right? Another 4 weeks, 6 weeks for the muscle to start to fire and function again. And then if it's a surgery, if a fusion, I'd say 12 weeks for bone healing. So really, if you think about the trunk, we cut through the back of this tube and it has to function again. So up and walking is the best thing for you. You know, therapeutic exercise is good, but really walking is a wonderful thing for patients to start moving their body. It's cardiovascularly driven and it's reciprocal motion, and the trunk actually does a ton. And just engage. And I usually want patients to take it easy because I've done it as a therapist, mobilize people too soon and the surgery can be compromised. Didn't really understand. And I've seen people have it happen. They rip the wound open, all kinds of stuff. You just want to let that happen naturally. And as more people move, but that's only taking care of a segmental problem. They have problems with inflammatory diet, morbid obesity, all these other things. It's like nutrition is probably a problem for you. If it's a box or a bag, don't eat it. Now, I love chips. I got my own personal problems with tobacco, right? But they're not here talking about me. This is about you. So it's like I would stay away from alcohol, drink as much water as you can. So now I'm starting to realize like my job is to guide people in wellness. And we didn't learn squat about that in medical school. Surgery is one thing, but your overall outcome would be influenced by all these other choices that you're making. With some patients, I tell them this is an opportunity for you to change your life. Young guys that have been working in construction for 20 years suddenly can't have that kind of job, and then they don't know what to do. And so it's like, is this an opportunity for you? It's challenging for patients, and it's hard for you to realize that unless you're in it yourself. I mean, your mortality is definitely challenged, frailty, getting older, all these things. It's like, oh my God. In some ways, you can use that as leverage with patients to say, is this the direction you want to continue to go in your life? I saw a patient today in the hospital get a lumbar surgery by another surgeon I was covering for them. The guy's a chronic alcoholic, dying from alcoholism. Hey, do you want to stop drinking? No. Okay, I'll see you later. I mean, he has no desire to change his life. But if you can get someone to buy into that, there's more to the job than just being a technician. Anybody can do a decompression, right? And so this goes back to your relationship with the patient and your ability to leverage their own need to change. So that's I do that sometimes, not all the time. If someone's open to that, I'll do it. But I'll talk to them about, ultimately my discharge plan for you as a spine patient is yoga. Some program where you're stretching and moving and you're active daily. That's kind of it.
I love that. I think it's huge. I mean, two parts. If we're looking at like the whole person, this concept of like nutrition, lifestyle, like even alcohol, there's all this concept of behaviors. And my experience, like seeing people who have gone through so much pain, it wasn't very often that it was a specific traumatic incident in which the pain came on. And it was kind of like, oh, I bent forward and my back hurt. And it's like all of a sudden their pain started to go down. And someone told me early on in my career, it was kind of like, it's an accumulation of stresses. It was kind of like the last straw that broke the camel's back. Right. And so it got me thinking about, okay, well, you go in and you get your surgery, you get fixed, right? You get tuned up, whatever parts that need to be fixed, they're fixed. But then we also have to make sure that our behaviors and habits, like even just the concept of like picking something up from the floor, we have to be able to do that properly, going into the mechanics themselves. Yeah, because if like, I like to think about it, and I've said this before to the clients that I work with, it's like your body's like a car, and truth be told, it's okay to every now and then for your rim to kind of hit the curb if you need to. You hit the curb because you're swerving out of the way, but if you hit the curb just once, you're fine. But if you keep hitting the curb enough, you're going to ding up your rim, you're going to start to lose air, you pretty much blow out a tire. I mean, and all of a sudden it's like you have to stop driving into the curb, which is also going to, one, protect you, but then also two, allow you to drive and do those activities a little bit longer. Right. So it was a story, and I often I don't think it's told enough. It's like, okay, you get your surgery, you get your PT, whatever you get, and you're fixed. in order for you to make those changes or keep those changes, you have to change what you're doing. And I really appreciate that you take the time out of your day to do that or during your sessions. And so when it comes to standard of care, Dr. Verdon, I think that's what the standard of care should be of what you're providing. So I really appreciate everything that you're sharing because yeah, we need to have a standard. And truth be told, interesting enough, and you may or may not experience this, but some people who when they're working with me, they're like, Ashley, you're so amazing. Not to, make my head blow up, but all I want to do is I just want to make sure that what I'm providing for the clients that I work with is the standard of care. And it kills me to know that the way that I operate isn't, right? And so that's where it is important for us to go to drive, push our professions a little bit harder into being able to provide a standard or set a standard. So that way more people can be helped. So again, I really appreciate all this.
Yeah, no, it's interesting you say. I was just thinking about talking to a gentleman who was working for a company, and it was around nutrition stuff. And he was a chiropractor, and he's now working for this uh, company that sells supplements. And we were talking about the biology of them, and I was impressed how much science went into this, and all of it made a ton of sense. And it should be standard. It's not. And it was interesting because we made a comment about, it's like, well, if someone's not interested, that's fine. I'm here to educate you and just move on. And I thought, in some ways, it's like this, David and Goliath. You're this little guy, you got this little rock, but you got a slingshot, and you're going after folks. And sometimes, if the truth is true because it's true. And what's true for you may not be true for somebody else. But as game acknowledges game, truth will acknowledge truth. And it'll be across disciplines. And it's so obvious you can't stop it. So if you're doing the right thing, no matter what, people will throw rocks at you. But the patients who you're helping will acknowledge that. I'm not for everybody. Not every patient who's ever come and seen me has been like, oh, fast. It's like, what do you mean no surgery? What are you talking about? Exercise? I'm not doing that. I have to lose weight? You want me to get my diabetes under control? No way. Can't you just fix me? And my answer is, we fix animals. You're not an animal. You're a human being, and you have some responsibility to what this skin suit that I got was given to me. I have some responsibility to take care of it. And I think if you honor that inside somebody else, you'll actually empower them, which is because, and then they empower you. So it's a reciprocal, you give and receive at one time. So every time I see a patient, I'm really doing that for myself. Yes, for them, but for me too. And I'm not, some days I have a bad day, I'm not the best, but like I try to honor that with people. And I think that's what I talk about, caregiving, right? And so, and then as you go on, you realize some of the stuff that you believe is what you were taught isn't true, or what you believe is wrong. And then you get to learn and grow. I'm starting to add new things to my practice because I think that they're important, that I should be offering them that. If I told my trainers this stuff, or they'd arrest me. So, but I think it's what's best for other people. That's what I would want for me. One of my partners used to tell me, would you offer this to your family member, to you, someone do it on you? And if the answer is always yes, then that's an easy question to answer, right?
For sure. Doing the right thing, showing the truth, and ultimately letting the results speak for themselves. If you're helping people, that's the big thing. And so
it's called practice for a reason.
Exactly.
That sounds stupid, but like, we're just going to do it and see what happens. It's, I hate to say it like that, but that's the truth. So, yeah. And then you take what you learned and you apply it to the next patient.
Yeah.
So it's true. Like it's a body of knowledge that you add to every patient interaction that you have.
I like to think about every patient interaction as a learning experience and also as an opportunity to help. But I mean, with
Opportunity.
every increasing experience, I like to say, like, listen, this interaction today, like, it just continues to get better the more information I get from you, the more that we can build this alliance. And so it's really huge. And so, Dr. Verdon, I mean, Dr. Verdon, thank you so much for your time and expertise. I think this
Yeah.
really shed a lot of light on surgery, people's approaches, and making it less scary, because going under the knife, being put under anesthesia in and itself is a very, very scary situation. And so being able to even reduce that fear is going to improve the outcomes significantly across all standpoints. And so for the folks who are listening, they're like, okay, yeah, Dr. Verdon makes a lot of sense. What's the best way to say, like, if they have questions, get in touch with you? But then also, I know that you are doing something really big and amazing that's actually going to be revolutionizing healthcare, right? And so, tell us a little bit more about that.
So we've taken this approach and digitized it. So over time, I was asked by friends and colleagues, hey, I have one of the hospitals I was at called a third pathway hospital. So a lot of my buddies are from Lahore, Pakistan, and they'd say, I have a friend, can you look at the films and tell me what to do? So we called that getting curbsided, right? Hey, tell us. I said, why can't you digitize that? And then I would start asking history questions of my friends who are not the patient. And I realized, can we digitize the questions? And then I started to really think about what I do, and really, I just learned how to run algorithms. One in physical medicine, PT, and another one in spine surgery. And we combined them, and we have a way to run an algorithm to come up with a potential diagnosis. And we were lucky to be able to show this to people during COVID, and it's a digital way to take in a patient. The one thing that we got asked is, that's great, that's a diagnosis, but what about triage? We don't even know, the right patient doesn't get to the right person at the right time most of the time. So we created we call it Spine Bot. It's a triage bot for spine patients. And we were able to take some questions and come up with a score that would predict where the patient should go based on their symptomatology and their severity. It's either go to the surgeon or a pain doctor or PT, right? So those three buckets, and it's right about 95% of the time, which is pretty darn accurate. And then in the midst of all that, we created a little company. It's called Transcendent Care Incorporated. It's www.transcendentcareinc.com. It's the landing page, but basically we're in 5 different clinics right now. We're launching in 2 other pretty large clinics in the Southeast, which we want to change the way that patients get scheduled. So now I want to go see the doctor. We're taking the approach of, I want to go where I can get the help as quick as I can. And so we're hoping to make it an operational efficiency across the system. So you don't go see the therapist when you need to see the surgeon, and you don't go see the surgeon when you need to see pain management. It's based on validated studies, and it's very accurate. So I think that I know that we can digitize care. I know that we can streamline care. I know we can make care more efficient. That's number one. But the real thing is, if you're put in front of the wrong person, they're going to have the wrong mindset treating you. So we need to get people to where they need to go. And then diagnostic accuracy needs to be better. So pain generator identification has to be standardized and must be improved. And we can do that. We've done that. So when we ran that little study, it originally was about 85% accurate. Right now, it's about the standard of care, which is analog, which is this. It's about 60% accurate. So just by digitizing things, we can improve significantly. And that's a very small change. I think it's going to get higher and higher as we add more factors in. And every time I've showed this to a doc, they get really excited about it. It's just a matter of getting it into the system. It's a low-cost way to improve care. It's across disciplines, and we believe you can do it for any ology. Anytime you run an algorithm, you can do this. So that means heart failure, diabetes, hypertension, symptom-driven care, gallbladder disease. Everything is symptom-driven. That's the only reason people show up to the doctor's office, except if it's a well visit. And then, honestly, then your care could be driven even by genetics and behavioral stuff. So we have a ton of data, but no tools to influence the direction of care. That's what's coming with machine learning Uh, there's all different components of machine learning that people don't talk about. The real challenge is this: are the clinicians going to sit by and let technology dictate to us what care is going to be, or are we going to code, learn about code, become fluent in the language of code, and become the subject matter experts required to digitize care? I want to be the latter. Digital medicine is coming. You can either be the bug or you can be the windshield. Like, I am not going to be the bug.
Let's make it happen.
The onus is going to be on people who can see the possibilities and apply knowledge, expertise, and work in groups to get that to happen. And it's going to happen. So, that's why I've committed probably the last 10 years of my career to doing this stuff. And it's a long sales cycle, but I don't care because I believe. So right now, what we have is an N of 1. When your career is over, all of your clinical experience is gone. Isn't that sad?
It's crazy.
You may write books, but your clinical experience and how you treat patients is gone. That's kind of unacceptable. Specifically when Jeff Bezos knows everything I've bought in the last 10 years. We have the technology to categorize and data pool information. My kids will not accept the fact that they don't get to take any of that knowledge and move it forward. So it's an evolution. We're at an evolutionary inflection in healthcare. And as far as I'm concerned, that's what's required.
For sure. I think it's important for clinicians to be able to really adapt because there's so many tools that can actually help us help our clients a little bit more. And so, so machine learning, the future of digitized healthcare can be an entirely other conversation. And I want to talk more about this because I think it's so important. But for the listeners out there who are like, Dr. Verdon, this was really helpful. What's the best way to get in touch if they have any questions, or if that's okay to just say, I just want to know, like, even if I'm not in the same state as you, I was really thankful for your episode today.
I'm on social media, kind of LinkedIn. So Michael P. Verdon, D-O, F-A-C-O-S is. They can even visit our website, my practice website, and ask questions if they choose to. I'm okay with that. That's www.daytonneurospine.com. Either one of those two, we'd be happy to reach out and get back to you and just reference this conversation, and I'll know what it's about. And that's probably the best two ways to get in touch with me.
Love it. Dr. Verdon, thank you again for your time. Really insightful, opening up the doors to so many, the standard of care and standard solution, but really making surgeries a lot less scary and providing people a direction to be able to say, this is what I can do. So thank you again.
Thank you. I appreciate the opportunity. You keep up the good work too on the therapy side. I see you.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.